Well, thank you.
Good evening, everyone, and welcome to our next installment of the Clinics webinar. My name is Dr. Muresh Mahlangu, and I am the Chief Medical Officer for Clinics Health Group. I'd like to welcome you tonight to our topic that will be given by Dr. Sipho Mabaso, which is Hydrocephalus overview. So a brief intro about Dr. Mabaso is that he is a neurosurgeon working at Tepo Temba Private Hospital, managing elective and emergency neurosurgical conditions. He obtained his Bachelor of Medicine and Surgery at University of Limpopo and his MMed in neurosurgery passed with distinction at UP. He then moved to Steve Biko Academic Hospital, where he was a registrar there, responsible for patient care, including emergencies, critical care, and surgical care, and neurosurgery training towards his FC neurosurgery and MMed degrees. Along with working at Clinics Tempo Temba Private Hospital, he is a neurosurgery specialist at Tembisa Private Provincial Tertiary Hospital, where he is managing clinical and administrative management of the neurosurgery department. I'd like to welcome for tonight's talk Dr. Sipho Mabaso. Thank you.
Evening. Thank you for the welcoming remarks. Thank you to Clinics for the opportunity. Thank you, Dr. Mafang. First, thank you to Clinics for the opportunity and the platform. So today, as I was thinking what I'm gonna talk about, I happen to just have a hydrocephalus patient. So I just then prepared from there. So this is a very broad topic. So I will go through a
Dr. Mabaso, you seem to have muted yourself. Oh, there you are.
Oh, okay. No. Yeah, so this is an overview, as I was saying. I'm not sure what I did on my side. So we'll go through just a few basics and a few important procedures that we do for hydrocephalus, and hopefully that will be it. Okay, so I think the other struggle I'm having is just to try and move. All right. All right. So what is hydrocephalus and what is exactly is called? So hydro is a word that means water. Cephalus, brain or head. So usually is water in the head. However, formally defined as imbalance between the production and absorption of cerebrospinal fluid, which is CSF. Usually, this results in increased intracranial pressure. There are a lot of other things that we've seen, obviously. We've seen ventriculomegaly or big ventricles on the scan, and usually this doesn't necessarily define hydrocephalus. You've heard about acquired versus congenital, where causes anything that happened after the person was born, versus congenital causes. Communicating versus non-communicating hydrocephalus. We've heard before we used to have obstructive versus non-obstructive. Well, we sort of moved away from the non-obstructive part because the belief is that all hydrocephalus is obstructive in nature. We might find that we say obstructive hydrocephalus, but non-obstructive hydrocephalus, obstructive that has sort of is falling off. So, in terms of pathophysiology and pathology of hydrocephalus, one needs obviously to understand CSF, its physiology, its production, its circulation, its absorption. So previously we had, or we still actually do have, CSF bulk flow theory. This is how we normally define the CSF that is produced by the choroid plexus. I usually even make an analogy where I say if you have CSF from the lateral ventricle, it will flow through to the third ventricle via the foramen Monro, then it will flow through the aqueduct of Sylvius there, and then it will go to the fourth ventricle. From there, it will go through the foramen of Luschka and Magendie, and then into the subarachnoid space, and then gets absorbed in the arachnoid granulation. So this is what we call bulk flow of CSF. So this is a theory. However, this theory has been questioned quite a number of times, especially as a cause of hydrocephalus. Once we study hydrocephalus, we realize that this is not a usual pathway for CSF. So that's why I call it a questionable theory. And actually, the world now is moving away from it. Reason for this is that when they do imaging studies, so like MRIs, CSF, cysternographies, there's not enough CSF in the arachnoid granulations that they could find. And then animal studies actually have shown that when they study the lymphatics, they'll find that there's actually a residue of CSF. It means that there's other pathways where that CSF goes through, other than it going to arachnoid granulations. So this then leaves more question as to then what exactly is a source of CSF and where does it go to from there. There are other conditions also. Maybe you might have seen the clinical settings where you have a patient with clear obstruction, dilated ventricles, and they asymptomatic. They just don't have signs of raised intracranial pressure. So according to bulk theory, this would have meant that this patient should be dead. So just a further on bulk theory, it says that on average per day, you get 500 mils of CSF. However, the space, ventricles plus the cisternal space contained is about 150 mils. So if you are getting 500 mils, that's between 450 and 750. So if that has to flow through 150 mils, that means you're gonna have about three times of CSF turnovers in a day. Now, if you have an obstruction and this 500 that must flow through must turn over 3 times in this space, you'll have raised intracranial pressure and DARCH. So this is also where this theory falls off. However, it has helped us a lot define hydrocephalus, the sites of obstruction, and also to come up with treatment modalities. All right, so where we are now is that CSF is a product of multiple mechanisms, different mechanisms from production, its circulation, and absorption. So there are a lot of different processes that are at play. So we'll start off with production. So yes, coral plexus is still believed to be the source, but at least maybe less than 80% of it produced through the aquaporin one. But there is also that CSF is a product of capillary fluid exchange driven by osmotic and hydrostatic pressure gradients all throughout the spaces, ventricular, mainly ventricular spaces. Then from there, the movement of CSF. There are two pathways that are believed to be the sites where CSF will move. So the normal pathway whereby CSF will move from throughout the ventricles and then go through the foramen of Luschka and go through into the cisternal space. This is what we call centripetal, so it goes around. So that still exists. However, when it gets to the surface of the brain, what has been the belief is that it doesn't necessarily go all of it to the arachnoid granulation, therefore to venous circulation. However, it goes to the spaces around the small arteries, mostly at the base of the brain, and these are called Virchow-Robin spaces. And then there by aquaporin 4 it gets transferred into the parenchyma. Okay, so that's one. And then some of it will eventually obviously use that venous outflow and get absorbed by the arachnoid granulation. Then there's a centrifugal pathway whereby we believe that within the ventricular space, CSF goes through the transependymal route. There was before a belief that CSF never goes through the ependyme. However, now we know that CSF does go through the ependyme. So then it will reach into the deep spaces, periarterial spaces, and then goes back into the circulation. The other thing, obviously, the capillary fluid exchange all throughout still happens. Now, the other very important point here is what now is another function of what we call coral plexus, is that coral plexus gives transmissions from the cardiac pulsation that gives a drive of CSF to flow. So that will give some hydrostatic pressure from the heart. So this is called Venn-Kessel system. Now the absorption is still a bit of an unclear point. However, as I've said, the lymphatic system so goes through the glial cells, the lymphatic system, or on the surface go to the cerebral lymphatics and get absorbed. Yes, and then the other part of it, obviously, we still believe that the arachnoid granulations are still there. So things have become more complicated, but there is obviously an understanding of why that is. How common is hydrocephalus? To be honest, I do not think that we have a full idea. Most of our data obviously is not entirely reflective of how hydrocephalus could be. This is a meta-analysis done by Isaacs and colleagues in 2018. So this is an update from 2018. Basically, they tried to go through multiple studies all across the world, try and see the incidence and prevalence of hydrocephalus. And of note is that they noted that Africa and South America have a very high number. Basically, approximately 85 per 100,000 individuals across the world will have hydrocephalus. And most of these will be the pediatric population. The premature babies, the number one cause was found to be intraventricular hemorrhages. And then the infants, this is the first year of life. Usually these ones will be congenital malformations, commonly aqueductal stenosis, Dandy Walker malformations, Chiari 2 malformations, kids that are born with spina bifida, MMC. And then the elderly population, the older they become, they develop what we call a normal pressure hydrocephalus. And more about 400 in per 100,000 over the age of 80. There is no obvious gender distribution according to their study. Okay, so as I said, bowel flow theory helped us a lot in defining this point, the point of obstruction model, because now we could able, by knowing the anatomy and the circulation of CSF, we could be able to say that if an obstruction is here, these are most likely the causes, and this is how we can do for the patient. So this is one of the coming from the hydrocephalus classification study group called the point of obstruction model as a cause of hydrocephalus, what differentials could be, and what would be the most likely effective treatment modalities for that. So from the lateral ventricles to the third ventricle, this is called an interventricular foramina. This is the foramen of Monro. You could have tumors there. Some of them, like your central neurocytomas. You can have an absence of foramen of Monro. You can have an infection or inflammation in the ventricular space, and then you can have obstruction of the foramen of Monro. So most of the time you have to shine. Now, from the third ventricle to the fourth ventricle, it's an aqueduct. Aqueduct simply meaning an outflow from the third ventricle. CSF flows into the fourth ventricle. This is what we call cerebral aqueduct, aqueduct of Sylvius. So tumors around the midbrain, the aqueduct is, there could be stenosis, can be acquired or congenital. And then that way you can have hydrocephalus, usually dilatation of the lateral and the third ventricle. And then within the fourth ventricle, we can have obstruction of the outflow. So obstruction at the level of foramen of Magendie, or obstruction of the level of Luschkas. Condition like your Chiari malformation, herniation of the tonsils down into the foramen magnum could give you this condition. Tumors, infection, and then now outside the ventricular space. So now this is what now we call communicating hydrocephalus. So outside the ventricular space, where there would be a communication between the ventricular space and the cisternal space, we could have bleeds there, like subarachnoid hemorrhage from ruptured aneurysm or from trauma, and end up causing you obstruction and hydrocephalus. And an infection like meningitis, TB, very common, especially in the immunocompromised population, fungal infection and viral infection. Beyond that, the arachnoid villi, so this is now right at the end, the arachnoid granulations. You can still have an infection, meningitis will still cause you a communicating hydrocephalus. The ventricles and the systemic spaces are communicating. Then you can have venous hypertension. So what is happening here, because CSF, according to the bulk flow, was supposedly flows into the venous space, back into the circulation. So if you've got an obstruction in the sinus, venous sinus thrombosis. Some patients, like patients with achondroplasias, patients with pseudotumor cerebri, they get venous hypertension. Then they get reduced absorption of CSF, and then therefore they develop hydrocephalus. Now, by age groups, this is one of the studies again that is presented on Schmidek. The most common causes of hydrocephalus worldwide, this is more than just this 344 patients, is the IVH of prematurity. The second cause is myelomeningocele. This is in the pediatric group. There is a bit of a competition between tumors and aqueductal stenosis, but I would argue that in our background, we see a lot of patients with aqueductal stenosis than we do with tumors. Infections, patients that have meningitis, head trauma in pediatrics and hydrocephalus is very rare in our setting. And sometimes there's more causes. Sometimes the patient just has hydrocephalus and we have no idea what causes it. Now, when we see adults, the issue with adults is that you either get an adult who comes with hydrocephalus that they had since they were babies. That's one. So the causes would have been whatever cause that they had, and they had a shunt. Now they're coming in with shunt malfunction or other complications of hydrocephalus. And then you get another group, sorry about adulthood. Another group where they will develop hydrocephalus with adults. So being obstructive, commonly tumors. Most tumors that present hydrocephalus is obstructive hydrocephalus. If we look at that point of obstruction model, it's clear. They could have communicating, especially the ones with infections, meningitis. We see quite a lot of TB meningitis in our setting. And then hypersecretory. Hypersecretory is a concept that was described long time ago by Walter Dendy in the 1980s, where they find that CSF can be overproduced by a tumor in the coral plexus and then cause them hydrocephalus. So the issue is too much volume of CSF. Then we have a normal pressure hydrocephalus, where this develops in the very elderly group. This is a unique form of hydrocephalus because we say it's normal pressure, yet hydrocephalus is defined as having high pressure. Here, the causes are not very, very clear. However, what is assumed to be the problem is that they have reduced capacity to reabsorb CSF. So they will present with dementia. Most of them usually think that they are demented. They will present with urinary incontinence and they will have unsteady gait. And you'd find that if you do maybe an LP or if you shunt them, they clinically improve, basically improve by removal of a large volume of CSF. Now, a bit on clinical signs in the young population. This is one of the pictures that I just usually like to go through. It's easy and I think I understand it better. So because of increased pressure, and these kids usually fontanelles are still open, sutures haven't really fused. They don't usually present acutely, like very acute in the sense that they will come even in a coma. But most of them will be irritable. And as pressure builds up, they start vomiting. Sometimes they are lethargic. Sometimes people don't know why the patient is actually sick until you examine and actually look at their head. Maybe the history that is there, this patient is lethargic and they have lethargic. Then eventually they'll have impaired level of consciousness. When you actually examine them, you'll note that the head is growing bigger, the fontanelle, anterior fontanelle is tense and full. They will have increased skull circumference. Most important signs are on the skin in the eyes and the fontanelle. They'll have very shine, thin scalp with prominent veins, dilated veins. They will have, due to compression of the tactile plate, they will have impaired upward gaze, what we call sunset appearance. They could have what we call foliar sign. They could have full coronate syndrome. Now, once the sutures have closed, the fontanelles have closed and the sutures have fused, the symptoms tend to, the way they present, it tends to be different. They tend to present more acute, especially with an acute obstruction from tumors or whatever other cause that they have. So they will have headaches is the most common. They will have signs of symptoms and signs of waist intestinal pressure. They can even come fitting, they can come in a coma. The picture on the right is what has made us to be best friends with the ophthalmologist. In a sense that we do fundoscopies, or we ask them to help us with the fundoscopy. And once we see papilledema, I will know that we are in real trouble. So the image that is there on the right shows us the fundi with an optic disc. You can see the blurring of the margin. You can see some haziness, and that shows that the papilla of the disc is actually swollen. Sometimes they can present with a very gradual onset of signs. So what I've already described as normal pressure hydrocephalus. This is the elderly group. This is called Hakim Adam triad. The cognitive dysfunction, the ataxic gait, and incontinence. And then sometimes patients will have signs of an underlying cause. So if there is a tumor obstructing CSF and it's in the posterior fossa, they could have cerebellar signs, or they could have signs of brainstem involvement, long tract signs, cranial nerve deficits. So we tend to try and examine them as much as we can. All right, so this is in the pediatric population, because you see a lot of hydrocephalus in the pediatric population really. So when we do see, we try and look for a cause, at least have a postulation as to what we suspect. And we know that certain syndromes like neurofibromatosis 1 is associated with aqueductal stenosis, and aqueductal stenosis then therefore be the cause of hydrocephalus. So we'll do examination even on the skin. See there, we look for carpal spots. We look for neurofibromas. Of note, in NF1, the carpal spots, they usually very small at that age, less than 5 millimeters. And as they grow, hit puberty and beyond puberty, they even go above 15 millimeters. And then you get neurofibromas, you get at least 6 of them, this is an NF1 patient or a reflexive form. X-linked hydrocephalus. This is a very standard way also of trying to come up with a cause, especially in the infant who comes in, they are a ball, X-linked, and they have hydrocephalus. The scan shows aqueductal stenosis. So simply looking to the thumbs, they tend to have adducted thumbs. So these ones, they tend to have serious underlying brain abnormalities, and then therefore they tend to have quite a poor long-term prognosis. Doesn't mean that we don't do anything. However, it's nice to know because we have to counsel families as well. So we'll examine patients with MMC. More than 80% of them will have hydrocephalus either on a presentation or after they've been referred. They have tend to have a type 1, type 2 Chiari malformation, and then therefore hydrocephalus. In terms of workup that we do, other than obviously blood workup that can be done for the sake of time, because I get to cover most of the things. Plain X-ray, not very useful when you want to diagnose hydrocephalus, but however, if one is working up a patient who's had hydrocephalus or has a shunt, we'd like to do a shunt series X-ray. So if it's a child, baby, we do a baby cram. But if it's an older child, we do a skull X-ray, neck X-ray, chest X-ray, abdominal X-ray. So as to see that if we suspect a shunt malformation, malfunction. A shunt malfunction, you want to exclude disconnected shunt, fractured shunt, or a kink of a shunt somewhere. We also use this to try and delineate as to what could be the cause of what could be the type of a shunt that the patient has. Imagine a situation where a patient is shunted maybe overseas or in Cape Town, and then they're now in our setting, and they come with a shunt. Now the decision whether you're gonna revise this shunt, you're gonna remove and put a new one, you wanna start and actually know what kind of a shunt is it. And then we can X-ray the actual shunt, and then these are the common shunt valves that are out there, and we can compare here. So a lot of information can come. One, you can know whether this is a programmable shunt, in which case, if there is a way to find the programming device, you can try and reprogram and see if the patient does improve. Maybe we needed to adjust the pressures. The second information, if you look, if it's an unprogrammable shunt, you get to know what pressure level of this shunt at when it was done. So the Medtronic Delta shunt use performance levels. We've seen it before as well. When you do an X-ray, it actually is radio opaque, all these markings. So you can see two dots with the Medtronic regular, which is the most common in the market. Will tell you this is a medium pressure. One dot shows it's a low pressure. Three dots to show that this is a high pressure. And then some pressures like some shunts with volume regulated shunts or flow regulated shunts, you see that the gravitational shunts. Then you know at least you have some ideas to what was done, and then you can plan from there. When we do a CT scan to diagnose hydrocephalus, there are a few criteria that we look at. Obviously, in our setting, scans seem to be now readily available. So patients get a lot of CT scans, CT brain scans. These are the criteria that we look at. Events ratio. Events ratio basically is the frontal horn to the internal diameter. Sorry, frontal horn to the biparietal diameter. This must be 30% of base for it to be hydrocephalus. If it is less, maybe it is not. So I apologize for that idea. They are also prerequisites. This patient must at least look at other markers. We also look at the temporal horn. It must be more than 2 meters, provided your Sylvan fissures, interhemispheric fissure, cell size are not visible, because if they are, and you have prominent temporal horns, you might be just having a patient with brain atrophy. The other thing, when you look at the temporal horn, then you look at this ratio. It's not evens, this one. It's a ratio that is independent. As I apologized before, frontal horn to internal frontal diameter. So this must be 50% of this and more for it to be hydrocephalus. Other things we look at, that ventricle is usually very thin. It's a slit-like, and if it is widened and larger, most likely dealing with hydrocephalus. Mickey Mouse sign, the frontal horn will sort of look like a Mickey Mouse. This you see mostly in the coronal CT scan. And then periventricular hypodensities, which is transependymal CSF seepage due to acute hydrocephalus, is quite an important sign. We do MRI. Okay, before I pass this point, there is a very huge debate on radiation risk. There's been findings that the more scans you get as a unit, as a child, you get there's a risk of developing cancers later on in life. So there are schools of thought whereby they believe that we need to limit scans, especially in units, and in people in places where they have actually MRIs readily available, they would rather do an MRI for a unit than do a CT scan. Now, on to MRI, very useful, gives us a lot of information. It helps us better to also tell what the cause of hydrocephalus is. The risk of radiation is less. However, MRIs, as you know, they are not readily available. They are expensive and they are time consuming. In a setting where you have a patient who's unstable, we can't be waiting for an MRI scan to finish so that we get your images, whereas a CT scan is a bit more quicker. Well, out of all the sequences, you do T1, weighted images, you do T2. Those will help you to see the ventricular spaces, if there are loculations or not. You'll also do studies that will help see what's happening within the ventricular space and cisterna space, like your fiesta cells, the fast imaging, employing steady state acquisition. So this image uses CSF sort of contrasting it so that you can be able to see the cisterna spaces better. Construction interface in steady state, it helps mainly to assess the flow of CSF. You can be able to see the areas where CSF is flowing, especially if you want to come up with a cause. This has done a lot. Yes, it's been done a lot in patients, assessing patients with aqueductal stenosis. Also very useful in normal patients with normal pressure hydrocephalus. Ultrasound. So ultrasound, very good tool. It is user dependent. It needs experience. It needs someone who knows what they are looking for. There are patients who get diagnosed with hydrocephalus before they are born. Some institution would have good fetal maternal units where the mother is even counseled with the hydrocephalus is diagnosed early. It's even counseled on the progression of the pregnancy, and they decide what they want to do after having had a diagnosis of hydrocephalus. And then once the baby is born, we can do ultrasound through the anterior fontanelle. The risk of radiation is less, but obviously we need a competent person, or at least you need to know how to do it. Because of time, I'm just gonna go straight through management and water management option, especially surgical management option, for various obvious reasons. We've seen many patients, they are shunted. So most patients that have hydrocephalus have shunts. So the types of shunts that are out there is what we call VP shunt, ventricular pleural shunt, ventricular atrial shunt. There is sometimes we do shunt out of the ventricle shunt from the lumbar. So some patients have had lumbar peritoneal shunts, but I think with time now those are sort of fading out now. Not many centers are still doing them. Then we have endoscopic procedures like endoscopic third ventriculostomy. This can be done also with a choroid plexus coagulation, so such that we try and reduce the function of choroid plexus. And then temporal diversion procedures, external ventricular drains, ventricular subgaleal shunt drains. Those are also some other type of procedures. But for the sake of time, I thought we're just going to look at the VP shunt and the endoscopic third ventriculostomy. Maybe when I'm invited again, I could make it a series so that we can go through a lot, because there's a lot on hydrocephalus. We can literally do at least 5 presentations on it. Okay, so when a person gets a shunt, it is important to note that a shunt is a permanent procedure. It's never temporary. If you are shunted, it means you need it. So we always tell our patients that, well, this is because we don't have any other site where we can your CSF is not getting absorbed in the normal pathway. So we're creating an alternative. So the alternative can be the peritoneum, alternative can be wherever we feel we can put, or we can create a distal absorptive site. So we aim to divert CSF from the ventricle to another site with good absorptive capacity. So peritoneum has proven over time, without a doubt, that is the best region to absorb CSF. So some of my surgical friends, they were feeling that we dump CSF in the peritoneum. And my answer is always that if we had other options, we would use them. But peritoneum is the best, and unfortunately, there is no other side. The most important thing is there must be a one-way flow through the shunt, prevent that it doesn't drain more, and the CSF doesn't go up and down the shunt. So shunt standard will consist of a proximal catheter. So this is a cranial or a ventricular catheter. There will be a valve that regulates the CSF flow and volume, and then there will be a distal catheter. So the valve is actually the most important thing when management. So these are the common valve types. We also do try and understand the causes of hydrocephalus. We also pair this with the age of the patient and what could be the ideal pressure for this patient be when we're choosing the valves. In an infant, where they still almost have sub-zero intracranial pressures, and we want to shunt them, we prefer low pressure valves. Reason being that you still obviously want to treat the hydrocephalus. So if you put a higher valve, it might not work. So once the fontanelles have closed, the sutures are fused, the head is well formed, the pressures tend to be a little higher. So when they do get hydrocephalus, medium pressure valves usually will suffice. With higher pressures, I'm sure we've seen patients who come in with hydrocephalus severe, they are neglected, the heads are larger, the brain is very thin. Whatever lower pressure you put, you will treat hydrocephalus, so you will drain the CSF. However, you might overdrain the CSF because they are functioning at higher pressure. So we opt for a higher pressure valve for that reason, that we want to drain only when it is high, but we don't want to overdrain and cause more pressure, because now we end up dealing with overdraining problems, hydrocephalus. And now programmable shunt valves. These are very complex valves. They different companies that makes them. As you can see down the programmable valves, 1, 2, 3, 4. All these might be in South Africa, some might not be. We most likely, most of the time, we have Medtronic, that is seen even in the public space. The programming devices are, so how these work, they work, use magnets. So you have put a shunt that's got a magnetic system that you can come back later and adjust without even having to operate the patient or try and remove the shunt. So you adjust with the device from outside. So because it's a magnet, if the patient was to walk into a magnetic field or we have an MRI, this will sort of semi-adjust and the pressures might change. There are many other reasons. So for whatever reason the shunt was put for, the patient might outgrow, might grow up, and the pressures change. The advantage is that you can always go back and report them. However, these are very expensive. And most patients that we see is patients from private. So if a patient comes into public space, one, you don't know how to program it because you don't have a programmer. And even maybe you could find out the type of a shunt. Because you can't program it, then you sometimes are forced to then remove it. So while they are very good in the term that they are in the sense that they are controllable, there might be a headache in the background where patients cannot be controlled or their shunts cannot be programmed. All right, so shunt, like I said, so we'll have a proximal catheter, we'll have a valve, and then we'll have a distal catheter or a distal site. So there are specific regions where we want to put a shunt. We have markers on the head, or mark areas that will mark on the head, and the aim is to aim for a site where there is a wider ventricular space. There's no choroid plexus, but number one cause of blocking of shunt blockage, especially in the ventricle, is choroid plexus. And this is frontal horn. Sometimes the lateral ventricular atrium is another most suitable site. So we use different sites and we place bare holes a specific site to try and achieve those sites. So the A is what we call a dentist point. So this is 3 millimeters laterally and the union 6 millimeters from the alternatively from the suture, onto suture, we could say 3 millimeters above and then 3 millimeters lateral. And then there is specific ways, obviously, that we try and place the catheter where we want it. Sometimes we use ultrasounds in some patients for optimal placement. Sometimes we use systems like navigation. They are different, but these three are the most common. Distal sites, when we're placing a distal catheter, like I said, peritoneal is our absolute preference. We do avoid it when the obvious abdominal or peritoneal diseases, sepsis, patients have extensive abdominal surgery. In some cases, we ask the general surgeons to help us because you need someone who's at least experienced with peritoneum. Pleural cavity, we're still gonna go through this. In very young children, it's not a good idea. This ventricular atrial shunt, VAS, this is where you put your shunt directly into the heart. When they sepsis systemically or locally, shunt is an absolute contraindicated. It's absolutely contraindicated. Okay, so a little bit on ventricular peritoneal shunt continuing from the proximal catheters, the abdominal access. So what we usually prefer is the right upper quadrant site, okay, or left upper quadrant site, depending on the case. Obviously, we ought to know the anatomy of the abdominal wall. For some of few reasons. The way we dissect the muscles and fascia, you must make sure that you dissect muscles, to cut the fascia parallel, and you don't do sharp dissection in the muscle. You must always find the posterior fascia. You must elevate it before you incise and get into the peritoneal space. Sometimes problems that could occur if you dissect too wide, you can cause hernias into the incisional site, into the surgical site later on. Or what could actually happen is that you could, while you are going, injure the intra-abdominal organs. We have to connect between the two sides. So shunt from there all the way to here, it must go under the skin. So we do tunneling. This is very painful, even when the patient is under anesthesia. And while you are tunneling using a hardware, there will be some restriction of the chest movement, causing ventilatory issues in theater. So the anesthesia team will always alert them and make sure that they are aware. Without wasting time, this is a ventricular pleural shunt. So here we put a distal catheter into the pleural space. We usually choose the anterior axillary line. We go through the superior border of the fifth rib, not the inferior border of the fifth rib, because we want to try and avoid the neurovascular bundle that's underneath. It is more complex in the sense that you need an experienced, obviously, doctor on the other side, because you might have to deflate the lung. So how you intubate the patient, how you then, so that you can be able to secure and deflate the lung that is on your operation site. So for you to insert, you might have to deflate. Once you've inserted, re-inflate again, put positive pressure ventilation while you are securing the shunt and closing, so as to avoid pneumothorax. Pleural effusion is a very common problem, hence we choose older children. Text says more than 7 years. Some people have tried to challenge it as low as 2 years, but the issue there, the pleural space is not very mature. So it will not absorb very well, and they will get pleural effusions and the ventilation problem, and then we'll end up having to do the shunts. So things like negative interthoracic pressure just by breathing could change a lot of dynamics in the shunt function. And sometimes shunts overdrain. So it's not really, that's why it's not really our first choice of surgical treatment procedure. Ventricular atrial shunt, VAS. So cranial part still the same. The change here becomes when it gets to a jugular vein, because now we're tunneling in a relatively shorter distance. There's two ways to access the jugular. We can use the internal or the external jugular. The aim mainly is to get the catheter into the right atrium. So the closed approach is where we use a Seldinger technique, just like putting in a CVP, where we put a catheter with a fillable choker, and then we able to use a J wire over that dual Seldinger technique to insert the distal catheter, then therefore tunnel it up. The other one is to do proper open, dissect all the way until you see the vein secure. We make a proper incision, put the securing sutures, whatever suture you put it, you suture on the vein or a hair string, and then you put a catheter and then you secure it. Ultrasound guidance is an absolute necessity. So if whenever we do, it should be. But I must say this is hardly ever done in it's just basic in there as a theoretical procedure for most centers. So when we shunt, the complications are relatively the same for all the shunt types. Shunt sepsis is one of number one complications. Shunt obstruction, shunt malfunction. Sometimes the shunts they break, they migrate. Sometimes the shunts they overdrain, and there's a overdrain, you get subdural hematomas. They can get later on slit ventricular syndrome from an earlier overdrainage. Sometimes they erode into the distal organs. So imagine sometimes you've seen a child coming in with a shunt through the rectum and the CSF draining. Sometimes they erode into the bladder. I think the patient is passing a lot of urine, and then you find that it is actually CSF. It can cause bowel obstructions. Yeah, we can have pseudocysts. So the complication rates really with shunts is quite high. In fact, the most shunts up to 30% they fail within 6 months. This is the latest data that is out there. And most shunts by 10 years would have been revised. So a shunt procedure is not an ideal procedure. However, there usually is not a lot of alternatives. So we then have to be aware that the first shunt that you ever get to do should be the one and should be the last, so that you never get to do it again. So the first shunt is the first shunt, and you should make sure that it's done properly. But because once you have to revise and revise another one or reinsert and things have changed, dynamics change altogether, and shunt failure rates just go up high. So the Hydrocephalus Network Research Center, they've come up with some protocols. However, what is actually suggested is that centers need to come up with their own protocols that work for them. Specific things, just like how we want to do a shunt procedure, we need to plan properly when we having a shunt patient. Images, proper history, make sure in some cases even do septic workup, because if a patient is septic, you can't shunt a patient. And then when we get to theater, we strict antiseptic protocols, antibiotic prophylaxis preoperatively, during the operation, surgeons' behaviors. Sometimes we ask surgeons to double glove. The way we clip the hair, usually we don't prefer using blade. If there is a clipper, we use a clipper. We try and limit the time from the clipping to the start of the operation. The theater set up, well, some centers don't have this, but there is what we call laminar flow. So theaters will have some flow to try and minimize the flora, the bacterial flora that's in the air, because that's what exactly will stick to the shunts and form biofilms in shunts. And unfortunately, this later on could lead to lung shunt infection. If you having a list of 5 patients, shunt must always be the first case in the morning. In theater, we limit the number of people, we stick to strict aseptic techniques, we close the door, we submerge shunts underwater all time, we make sure we never touch our shunts. And shunt surgery must be less than at least 30 minutes. So we prefer to have 2 surgeons in theater. So this is just a whole lot of information about how we do it, but it's just to emphasize how we want to avoid complications as much as possible. All right. The other very common procedure that we do for hydrocephalus, I'm almost done, basically. It's what we call endoscopic bed ventriculostomy. So the world noticing that shunts have a lot of problems. Around about 1970, 78, this procedure was now revamped, or it resurfaced. And in some areas, and actually even more so here in Africa, in Uganda, they will do more ETVs than they actually do shunts. Reason for that is because the complication rate, as they believe with their experience, is that it is less. And most of these problems that are associated with shunts are less. However, obviously, everything works with experience. So you find that in some first world countries, ATVs are not such a huge success as they are in their hands. So we use an endoscope to create a stoma in the floor of the third ventricle. Usually we prefer a rigid scope. The reason for that, a rigid scope, for the longest of time, it had a better resolution, but now things have changed. Even the flexible resolution has improved. In terms of working chambers, so on the image on the right, this is a rigid scope. It doesn't turn, just a fixed screw that goes in through there. So you have at least 1, 2, 3 working channels. So you are able to work better than you would with this very small and flexible. It has less chambers and times now. So we would go frontal the hole, get into the lateral ventricle, both in the foramen of Monro, get into the third ventricle, and then flow of the third ventricle, hence third ventriculostomy, create a stoma. There is very interesting history to this. It's a very old procedure that was used for some time, abandoned due to complications and mortalities, and then resurfaced in 1970s. So around about 1910, urology, Dr. Vincent Lespinasse, he did it in 2 infants. One died, one lived for 5 years. He was using a cystoscope. In 1918, Dendi did a few of ventriculostomy, but he was doing them open without a scope. But the key here is that he was creating a stoma in the third ventricle, in the lamina terminalis, and then let CSF flow. Therefore, bypass if there is any cause like aqueductal stenosis, bypass that. Interesting enough, the first successful ETV was a urologist, Mr. Dr. William J. Mixter, and he did it in a 9-month-old using a retroscopy, and it was successful. However, due to complications, due to mortalities, it was abandoned for some time, and it resurfaced just before the 1980s. Which patients we likely to do ETVs on? Patients with obvious obstructive hydrocephalus, especially at the level of an aqueduct. Patients with tumors there, patients with aqueductal stenosis, they even have a high success rate. The patients that we are less likely to do is patients with communicating hydrocephalus, like post-infectious hydrocephalus, because there is a clear communication between the ventricle and the cisternal space. So even if you do you do create a stoma to communicate the two spaces, you still have a problem. So patients with post-hemorrhagic patients with myelomeningocele, this used to be a problem, but as time goes now, we are actually doing ETV on them. So the key is that the ventricles must have high pressures compared to the cisternal space. That's why an obstructive cause is much more useful. This creates obviously a pressure gradient along the stoma and precipitating. So Kulkarni and colleagues did a study where they came up with a success score of ETVs. This looking at about 3 months. And they're looking at the age of patients and the etiologies that the patient have and which ones are less likely to be successful. So the younger the child, the chances are that it will not be successful. The score will be 0. Post-infectious hydrocephalus, those are communicating, and it will most likely be 0. Whether they've had a shunt before, if they've never had a shunt, maybe you can give it a chance. You can have a 10% success. But if you note aqueductal stenosis, tactile tumors, they still cause obstruction at the aqueduct. The success rate is high, and the older you go, even above 10 years old, the success rate is high. So essentially, ETV can be done for older people older than 10 more successfully than they can be done for younger patients. This is what is still standing, but more research is still happening. All right, so like you saw that we can do an ETV in a patient who's had a failed shunt before. We need to know the cause. We need to know if the patient has a previous infections, and we need to know if it was a hemorrhagic cause. We need to know what type of hydrocephalus they have. The major drawback in our setting for ETV, though it is an arguable point for some people, that we need an MRI. MRI because you get a better understanding as to the structures that ventricle getting into the ventricle. A lot of information you need from an MRI. Going down through the foramen of Mons, the size of the foramen of Mons dictates, the size of the ventricles dictates, the size of the third ventricle dictates. All this information will be better on an MRI. The floor where you're gonna go, this is the floor where you're gonna go. You need to see if there are no pathologies that will enter you here. Sometimes you have a basilar artery right in your way. All this you need a better imaging for. So we need an MRI. And then also we need an MRI because most of these are obstructive causes. So you need to diagnose it. So you do the sequences as the T1, your T2, your fiestas, your cis. This helps us, especially if you have an aqueductal stenosis, to actually even see if there's any flow through the aqueduct form. Complications are a lot. Patient most commonly is the ones that are related to the procedure itself. So injury to the brain, injury to the foramen of Mons, or bleeding as you go through the ventricles. Bleeding through as you go through the ventricles, injury to the fornix, which results in cognitive memory issues, injury to the hypothalamus, injury to the basilar artery, which is a very bad injury, and the patient can actually die in the chair. So those are the ones. And then other than that, sepsis is very common, and CSF leak, and you can bleed while you are doing the bleeding. I'd like to end here. I hope it's been a useful talk. I'll listen for questions. Thank you.
Thank you. And thank you very much, Dr. Mabaso. That was a highly informative talk. So I did see we've got 2 questions here. The first question is, what are the causes of recurrent hydrocephalus? How to differentiate them? And how do we differentiate them from a superimposed infection meningitis?
It's a very loaded question. First, I'll start with the second question. So a superimposed post-infectious infectious hydrocephalus, right? And then the first one is the recurrent hydrocephalus. The nature of hydrocephalus shouldn't really be that it recurs, because it's not really a treatable condition. Once you have it, usually that you've had it, you have it forever. Hence, you opt for permanent procedures like shunting. So recurrent, I will understand, or I will think that you had a shunt before, you had a hydrocephalus, you had a shunt, maybe shunt malfunctioned, and then you had still features of acute hydrocephalus because whatever procedure was done, and then maybe there's a recurrent symptom. I'm just thinking this is where the line of questioning is. With infection now, infection, it depends of what kind of type of infection you have that gives you hydrocephalus. So normally your meningitis will cause you communicating hydrocephalus. So when the two spaces are communicating, like I said, ventricle system, you can investigate, you can do an LP for these patients, and especially for TB meningitis, I think I've mentioned it before. We can even do an LP. Some other patients with hydrocephalus, acute tropical meningitis, with it causing hydrocephalus, we can do LPs and decide on the shunt later. I'm not too sure if I'm answering the question right, because it was a bit loaded. Hello?
Hi, yes, I'm not too
Yeah.
sure if the doctor would like to let us know if they have
Yes, no,
answered it.
I'm open to just engage a little bit more. It's a loaded question.
It's a really
Because I have to just break down a little bit on what could be recurrent hydrocephalus. When there is superimposed infection, it's unusual, but it's not that it can never happen. Like I said, the causes can be multiple causes. So, yeah, it's a bit of a loaded question. I'm not very clear what it's seeking to answer.
Okay. All
Yeah.
right. Dr. Mokhtar will let us know if he's been answered. Okay, I don't see him in the things. Let's move on to the next question. The next question is, what is the prognosis of the head size after successful shunting?
Okay. To answer this question, it's a bit of a hard. Okay, so the head is a result of pressure. Usually, if before the closure of the fontanelle or the fusion of the sutures, and you able to shunt early, you are able to get a better outcome in terms of managing the growth of the head, meaning that the head hadn't grown that much, and it was still at that stage where you can remold with if you reduce the pressures. However, if a patient presents a little bit later, when they are already sutures are closed, fontanelles, so anterior fontanelles are closed completely, and the head is already fused fully and it is large. So in this, whatever you do, you enchant the patient, the head size unfortunately doesn't change. So cosmetically, I think it's a serious morbidity. You've seen some patients that you actually get a feeling that their heads are heavy. One other thing about hydrocephalus is that sometimes you've seen that you shunt a patient and you hear that the shunt is working, but you still get when you see them next, you still get a feeling that the head size keeps on getting bigger. this is part, I think, of a research that's still ongoing. But the bone morphogenic factors that we think they get released once the pressures go up, and um, the head will continue growing even if you reduce the pressure, just because they've been in that state. However, if you shun them early now, the head usually the head size is usually controllable.
Okay.
That's my final question, answer to that question.
Thank you. I saw in one of your first slides, in some of the beginning of your slides, where you quoted one of your references with the causes in children, and you said in our setting it's a bit difficult, and I may have missed that, but in our setting in South Africa, what would be the top 3 causes of hydrocephalus in children?
Okay, so yes. So I'll group that question again. So in neonates or in infancy, the number 1 cause is usually congenital malformation. Congenital malformations, and top of that, there is 3. There's aqueductal stenosis. There is a Chiari-2 malformation, babies that are born with MMC. The third one is patients that come with Dandy-Walker malformation. And then this is the children. So the premature babies, Papil has done a lot of work on this and graded them as well. They tend to have hemorrhages that have intraventricular hemorrhages, and then therefore they develop hydrocephalus. So in a premature baby, before 36, 35 weeks of gestation, and they bleed in the head. That's one of the very common causes. So I would put that possible number 2. And then the next will be infections. This is in the pediatric group. However, on the flip side, if you go to adults, patients who come in with hydrocephalus, still not trauma. Number one cause, patients who come with lesions, patients with tumors that cause obstruction. And then we know we have a lot of intracranial hemorrhages, also incidents in South Africa. Subarachnoid, some other causes of the ICHs. That to be that's another very common group that we see quite a lot. And then infections, mostly TB meningitis, cryptococcal meningitis. So that group also in adults tend to be quite common as well. Unfortunately, they are immunocompromised. Most of them don't really.
Thank you.
So this is just out of my own experience.
Well, I mean, sometimes our experience rings true in a lot of in our practices and what we see. But Dr. Mabaso, I just want to thank you so very much. It was actually very informative to see that, unfortunately, that the prevalence of hydrocephalus is still quite high
Yes.
within the continent of Africa, which means that it is still something that is a condition that's still very important within the medical field for all of us, to always be on the lookout for children and especially in adults. I want to thank you for your excellent presentation that you've given us tonight. Obviously, we will see you back soon another time. And I want to thank everybody who has joined us tonight for this talk. And we will see everybody at our next webinar. Please look out for our next invite. And once again, thank you from the clinics team. Good night, everyone.
All right. Thank you. Thank you very much.
Thank you.